Welcome back to Tube Talk, everyone. I'm Brian Miller, one of your Associate System Medical Directors, here with episode number 5 now, and it's all about bougies. In our previous episodes, we covered the 5 tips for intubation success and gone into detail on each of those topics. Today, we're going to do a deep dive into the bougie use and the tube delivery aspect of our intubations. We continue to watch your videos out there in the system, and we see a lot of great and successful techniques out there. However, we still have some room to grow as a system for our intubation success rates. So let's continue our learning today and jump right into episode number 5 now. As always, let's review our 5 tips for intubation success again. That's obtaining a 50-50 view every single time, deliberately curving our bougie, which we'll talk about in just a second, always staying midline, suctioning before and as needed during our intubations, and the for bougie or tube hang-up, performing the rings right or in left maneuvers, which we'll also discuss in just a bit. This episode is going to be divided into 2 portions. First, we're going to discuss the curve of the bougie during our preparation and some best practices for bougie delivery and troubleshooting. Then we're going to finish up with tube delivery as well as some safeguards to ensure that we have the highest likelihood of success on our intubation at the end. When we grab our bougies out of our bag, it's often in a U-shaped curve and fairly straight at the ends except for the coude tip, or a little bit more mangled if it's been in our bag a little bit longer. Our goal though is to increase the curve of that bougie a bit though. And so what we're going to do is grab that coude tip or that angled tip in the palm of our hand, and then we're going to wrap it around our hand to increase that curve. So we're going to grab it at the coude tip, wrap it around, and that's going to create a curve like this. You see it's a nice gradual curve all the way down to the coude tip. I caution you, you don't want to be increasing the coude tip's curve too much. That will cause bougie hang up and be very difficult to overcome. So that gradual curve is what we're looking for right there. And as you can see, that's what matches the blade and is what's going to increase our success overall. As we recall, the UE scope has that 45-degree angle at the tip of the blade, which gives us those really nice views. This initial bougie prep is important, and that is why it is also included as part of the intubation prep section on the airway checklist. If we have no bougie curve, it can't overcome the angle of the blade at the end and will go posterior. If we curve that bougie, it will follow that blade nicely right into the glottis. An error we sometimes see in videos is the premature use of the bougie. What occurs here is the intubator jumps the gun and hasn't even fully positioned the blade or obtained the optimal view yet, but is simultaneously trying to insert and attempt to pass the bougie. This distracts us from what we should be doing, and since our right hand is already tied up with the bougie then, no suction is often utilized where it should be. The proper sequence thus should be our scissor blade suction, then clear the path of our blade with our suction, establish that 50-50 view, and get our blade positioned nice and midline. Then you get your bougie and pass it. Here's a quick video to highlight what we were talking about right here. This is a cardiac arrest airway, and the intubator uses a styletted tube instead of a bougie first approach as we've always discussed. However, the same principles between a tube and a bougie being prematurely inserted apply in this case. Here we are, scissor blade, however no suction comes in initially, and then we immediately dab our blade on the back of the throat right here. You can see it bouncing up and down with chest compressions. As we talked about, this is a high likelihood for blade contamination, especially early in our intubation when we do this. Now we pick it up and continue down. However, we're on the far right side of that airway, and we've loaded that tongue on that left side. We get some visualization of that epiglottis on the top left, however our blade is off midline, and we certainly haven't obtained a 50-50 view. It's also a pretty goopy airway, definitely needed suction coming in. However, now we have the tube coming in instead. So instead of focusing on getting our 50-50 view and being midline, we're focusing on the tube now. Also, our right hand is now tied up, and we can't suction as we're advancing because that tube is now on that right side of that airway. And so we're going to see the tube come back in again, and it's actually going to obstruct our view in a second, so we can't even see everything right here. And so this is ultimately an unsuccessful airway, at least in part somewhat from placing the tube too early. Another issue we occasionally see is the use of the tube loaded way too far down the bougie, almost to the point of using the bougie as a stylet with either no or only a tiny tip of the bougie actually sticking out. This makes the bougie much more rigid and generally negates all the advantages of the bougie, including its low profile that can easily pass through the airway and to minimize the obstruction of our view. It additionally stiffens the bougie up and reduces the gentle curve we talked about that is beneficial. I would highly encourage everyone to do the solo bougie method, aka a bougie without a tube preloaded on it, as that maximizes the ability to manipulate that bougie. Or if you'd like, just preload the tube but keep it up high on your bougie until the bougie has actually been passed down into the airway and you are ready to railroad the tube down. Let's go to a video now to highlight this a bit more. This is a cardiac arrest airway again, and so what we're going to see is a scissor blade suction come in. Suction's a little bit shallow, not a really contaminated airway, so we get away with that. However, we park our blade a little bit short. We're not in that hyoepiglottic ligament, and then we see our tube immediately come in right here. However, it's got the bougie just a little bit hanging out, and so here we see all that difficulty. We see a fairly rigid thing that's intermittently obstructing our view, and it's darting posteriorly there, as that gentle curve is not working to our favor in this case. And so we continue to have difficulty with this. Retract the tube a little bit back on it. However, our bougie is still not really doing what we would like it to do, and we continue to be part short in that airway, and it's ultimately an unsuccessful attempt. I do want to discuss the concept of posterior bougie deflection. This is where the top teeth act as a fulcrum and pivot or direct the bougie posteriorly towards the esophagus. As you can see in the picture on the left side, the bougie isn't really being inserted from the corner of the mouth, and then on the video screen you can see that the bougie is darting posteriorly. On the right picture is a model of this, where the gray stylet bar represents the teeth, and again you can see the bougie coming in from the midline and going towards the esophagus right there. This concept is important to us, as we should, especially for patients with a full set of teeth, avoid inserting the bougie in the midline and instead enter from the corner of the mouth to avoid this phenomenon from happening and making our intubation much more difficult. This is a live action video now from George Kovacs, one of the preeminent airway educators out there. As you can see, the bougie is being inserted on the midline of the teeth, and it slides down posteriorly right there into the esophagus. Now we're trying to pivot the bougie, but it pivots right on those teeth and acts as a fulcrum and continues to go posteriorly. So this is why it's so important to enter from the corner of the mouth rather than on the teeth themselves. Now that we've discussed a couple of difficulties we can try and avoid causing ourselves, let's cover our algorithm for what to do if the bougie is not going where we want or passing into the glottis. While it's a somewhat cheesy mnemonic, we hope in the moment it may be something you can refer to in your head. It's EGI, or every good intubation, and is a few things that you can do or quickly change to get the bougie to be directed into the glottis easier. These are: ensure or double check you actually have a 50-50 view. Maybe you're actually more of a 70-30 view, and you can back off that view a bit, which might lessen the curve of that bougie that it has to take. Next, make sure your glottis is midline. If both of these are good, or you're corrected them, next consider increasing the bougie curve, especially if you had the bougie pre-curve for a bit before your attempt or had your partner do it, as it may have straightened out a bit or wasn't properly curved all the way. Finally, if all of those don't work out, no tool is 100%, so maybe the bougie wasn't best for your patient, and you can consider starting a fresh attempt again with a bougie, or consider switching to a styleted tube. The key is to keep progressing and optimizing, not just doing the same thing over and over and over and burning up time during your intubation. Let's now move to the second portion of this episode, which is our troubleshooting of bougie and tube hang-up, as well as our final steps after passing the tube. As a review, for the bougie hang-up, the most common cause is the coude tip catching on the anterior tracheal rings. This is where we do our rings right maneuver and pivot the bougie 90 degrees and take that tip off of those rings to allow it to advance smoothly. Sometimes you may have to slightly jiggle or loosen the bougie from the rings and then allow it to rotate. In rarer cases, the bougie may actually have to be reflexively rotated as you enter the glottis to allow it to clear. Here's a quick video of this maneuver in action. Here we are, scissor blade suction. Suction's on the left side, which is incorrect. We should have been coming in from the right side, but this doesn't cause us too much trouble, and it's overall a clean airway. We get down generally midline here and have a pretty good 50-50 view, which allows the bougie to come in and pass easily. However, we have bougie hang up here on the anterior tracheal rings, do our quick right turn, and then are able to pass the bougie down to the 30 centimeter mark. And here comes the tube, no hang up there. You see the black line pass, we're at an adequate depth, and this is ultimately a successful airway. Occasionally you will see the bougie tip get stuck just past the cords, but it just won't pass further down despite attempting the rings right maneuver. This can be very frustrating and is what I refer to as refractory bougie hang-up, since it doesn't respond to our standard maneuvers. Our steps if we encounter this are similar but a bit different from those that we just talked about for when we were having difficulty actually getting the bougie into the glottis altogether. So what do we do? First, always check your view to ensure you're not too deep, as this is one of the most common reasons. Second, reduce or drop the angle of your bougie. Sometimes we are attempting to insert the bougie almost perpendicular to the trachea from the mouth. Reduce that angle to as parallel to the trachea, and this may help. Next, you can consider straightening the bougie out a bit if you think you put too much curve on it. The most common thing I see done, though, is a very careful insertion of the tube. This is usually fairly successful and usually the most efficient. Remember, you only have less than a centimeter of bougie in, so it can easily fall out. So you have to be very meticulous and diligent in maintaining it in position and verifying that your tube doesn't fall out and go esophageal. Finally, if you're still having trouble, consider switching to a stylated tube as a backup. Let's take a look at one of those refractory bougie hanging up cases now. Here we are, scissor blade suction. Suction is leading the path of the blade and clearing it of secretions. We also have a fairly large tongue that we're utilizing suction to displace it out of the way, which is a great move. There's the uvula as our indicator for our midline landmark, and then we ultimately end up on the right side of it. So this is a drug-assisted airway with ketamine, with a breathing patient with all these lacy secretions and also those secretions being breathed back at us, which makes it a little bit more difficult. So the intubator gets lost here for a little bit, so we're going to pause and go ahead about 30 seconds. And now we finally got a good view, and we see the bougie come in. A little bit of difficulty passing the bougie initially, however then it goes just past the cords and gets completely hung up. Here the intubator tries a rings right maneuver, which is ultimately unsuccessful as well, and the bougie continues to get hung just past the cords. So this is that refractory bougie hang up. So we're a little bit deep on our view right here, not quite at 50-50, so we could come back off our view a little bit. We could also consider reducing the angle of attack of our bougie and get it a little bit more parallel to the trachea on insertion, and then we can also consider straightening out our bougie a bit. However, the intubator goes with the past the tube approach here, which is ultimately successful. And so we're going to see the tube come in just a second, and it passes nicely. What I like is that they're very diligent and watching for that bougie falling out, and ultimately this is a successful intubation with a confirmed tube. Now let's go over tube hang up. This is where the tip of the endotracheal tube gets stuck on typically the right arytenoid of the glottis. The first thing we should do is retract the tube a centimeter or two. This is important as we don't want to be trying to pivot the tube on the soft tissues themselves, as that makes it much more difficult. Once we've retracted a bit, we should then rotate the tube 90 degrees counterclockwise or to the left to bring the point of the tube directly into the middle of the airway and allow it to pass unimpeded. Let's take a look at a video to see how this goes. This is another example of a drug-assisted airway with ketamine with the patient breathing. So here we are, scissor, blade, however no suction. We do have some of those frothy secretions consistent with ketamine, however not too much trouble with that. We advance the blade down into a 50-50 and midline view, and here comes the bougie now. We do have some spasm and coughing initially, but we're patient with that and slowly advance the bougie and eventually get down to hold up. Again, it would have been nice to have had some suction to have cleared our view right here, but overall not too bad. And here comes the tube now, and the tube is going to get immediate hold up right here. We're going to try and force our way in. However, we're stuck on that right arytenoid, as we can see right here. What we should have done is retracted that tube back about 1 to 2 centimeters now and done that rotation counterclockwise or to the left to bypass this. So we try some half maneuvers each way to the left and then to the right, and then we finally rotate and pivot that point of that tube to the middle of the airway now. We're patient again and wait for the patient to take a deep breath, and then we advance the tube down with the black line passed, and this is ultimately a successful airway. Alright, now that we've covered bougie stuff all the way from preparation down to it actually passing into the airway and a bit about tube hang up, let's go over our next moves after that and our exit plan. First, once the bougie is placed, don't move the blade. Maintain the blade in position for tube delivery. By maintaining the blade in that position, you can keep all the soft tissues out of the way of the tube while it's being railroaded down the bougie into the trachea, and it also allows visualization of any challenges such as tube hang up. Once the tube is down, consider inflating the cuff prior to the bougie removal to reduce the risk of tube displacement. You should also still keep your blade in for the bougie to be removed, as you can then watch out for the tube being completely displaced or just pulled slightly out where the balloon is above the cords, or what's called the hypopharyngeal position. Both of these can be detected and corrected if we continue to watch our tube. Finally, consider direct visualization all the way through your first breath or two of BVM ventilation and the end tidal confirmation. These steps are much more important though in those patients we expect to produce very low levels of end tidal CO2, such as very prolonged downtimes and those traumatic arrests with a severe hemorrhage component. Our goal out of all of these moves is to remove as many technical factors as possible that could occur with our tube. Obviously, end tidal CO2 is still the gold standard, but these are all insurance policies on your tube. Now let's move into our last video of the episode to highlight these final intubation steps. This is a drug-assisted airway again with the patient breathing throughout the intubation. So we see scissor, blade, and we are at the tip of the tongue here waiting for suction to come in, and there's suction right there, which clears the path of the blade to those lacy and frothy secretions that we see often with our drug-assisted airways. A little bit of difficulty getting around the tongue right here. We're also off to the left side a little bit, and here we correct back to the midline right there as confirmed by the uvula right there in the middle, and now we're working our way down into the vallecula. We see a little bit of extra secretions right here that could have been suctioned to have kept our airway a little bit cleaner, and now we place the blade generally into the vallecula. You can see we're a little bit off of that ligament right there, but we get a pretty good 50-50 view right here now. You can see the patient continuously breathing throughout all of this. However, we're not having any kind of laryngospasm going on, which is nice. And since we set ourselves up for success, the bougie passes really easily through the chords right there. There's 15, there's 20, there's 25 right about now. So we are down to hold up. And so this airway is generally on lock now from our bougie. And now we're just railroading our tube down along that bougie. We've been maintaining our blade throughout all of this to keep all those soft tissues out of the way. And here's the tube pass. Black line is now past the cords. And we maintain our blade, and you see the bougie being removed here. Now what you're going to see is that pro move that we talked about. You can see them ventilating, and you can see condensation in this tube. So you're visualizing end-tidal CO2 on your monitor, and you're also seeing good conformation of your tube in the airway as well. Well, that wraps up episode number 5 of Tube Talk, everyone. At this point, we've completed out our 5 tips for intubation success series. We are now going to try and change Tube Talk up a bit and give you much shorter episodes on a more periodic basis when we see a topic or video we think would be beneficial to be shared with the system. I also want to place a plug and remind everyone about the airway checklist available on your VL boxes and on the Protocol app. Our goal is for the checklist to be utilized on every airway for both patient safety and to maximize our intubation success. As always, for any questions, don't hesitate to reach out to myself or anyone in the OMD, and may your next intubation be successful, and until next time, take care and be safe, everyone.